Hello everyone. A 60-year-old male presented to the OPD with complaints of painless hematuria. Hematuria means blood in urine. An ultrasonogram revealed a 2 cm mass in the urinary bladder. The patient underwent cystoscopy and a tumor resection was done at the same time. To be able to solve cases like this, you need to understand the anatomy of the urinary bladder. We will describe and demonstrate the urinary bladder under the following subheadings: position, features, important peritoneal and other relations, blood supply, nerve supply, lymphatic drainage, and clinical aspects. Two important competencies which we need to cover are: explain the anatomical basis of suprapubic cystostomy and describe the neurological basis of automatic bladder. The urinary bladder is a hollow viscus with muscular walls whose main function is to store urine and help in the voiding of urine. It is a hollow viscus to allow it to accommodate the urine, and its walls are muscular to give it distensibility as well as the ability to contract when the urine has to be expelled. The muscle which is forming its wall is known as detrusor. Its size, shape and position and relations vary according to its content. When we talk about the position of the urinary bladder, there are certain things which we need to understand. The urinary bladder is separated from the pubic bones by this space which is called the retropubic space. The retropubic space separates the urinary bladder from the pubic bone, and the urinary bladder lies posterior to the pubic bones and the pubic symphysis. The upper border of the urinary bladder is in line with the upper border of the pubic symphysis, and the neck of the urinary bladder, that is the lowermost portion where it becomes continuous with the urethra, is about 3 to 4 centimeters behind the pubic symphysis, the lower end of the pubic symphysis, and it is just a little bit above the pubic symphysis, right? So these are important points to remember, that its superior border is at the level of the upper border of the pubic symphysis, and its lowermost portion, that is the neck of the urinary bladder, is posterior to 3 to 4 centimeters posterior to the pubic symphysis and just a little bit above its level. Depending upon the amount of content of the urinary bladder, the surfaces and the borders of the urinary bladder differ. Now we will start with when the bladder is empty. An empty bladder is tetrahedral in shape. Since there is no way I can show you a gross specimen, so let's take a simile. So first fold your hands as if you are going to pray. Now see to it, now position them in such a way that they are at right angles to your chest, right? The tips of your fingers are facing forward, the thumbs are facing superiorly, right? Now when you are in this particular position, we imagine this is an empty urinary bladder. Now let me teach you the surfaces on this, and then I will come on to the picture. Now when you are looking at this, let's start with the surfaces. The tip of your index fingers are the apex of the urinary bladder. Right opposite the apex is going to be the base. So the wrist, where your wrists are, the surface of your hands in between your wrists, which is facing towards your chest, is the base of the urinary bladder. The surface where you can see the thumbs, this is the superior surface, and the dorsum of both your hands forms the inferior lateral surfaces. So we have an apex, a base, a superior surface, and the inferior lateral surfaces. Surfaces are separated by borders. So the tips of all your fingers form the anterior border. The index fingers of both the sides form the lateral border. And whatever would be joining an imaginary line which is going to be joining which would be separating the superior surface from the base would be the posterior border. Now let's see this on this picture. This is the apex of the urinary bladder, right? Right opposite the apex is the base. So this part, which is in between where the two angles where the ureters are joining and thereafter, or entering, not joining, the ureters are entering the urinary bladder, and this portion would be the base of the urinary bladder. Okay, forget the transparency, ignore the transparency. You're looking at the base of the urinary bladder. This surface would be the superior surface. This surface would be the inferior lateral surfaces. The two sides inferior lateral surfaces are separated by this, which is the anterior border. The inferior lateral surfaces are separated from the superior surface by this, which is the lateral border, and the superior surface is separated from the base by this border, which is the posterior border. Wherever the two inferior lateral surfaces, the base, all these surfaces are coming in contact, that is the area from where the urethra is starting, and that is the area of the neck of the urinary bladder, would be somewhere here, where the urinary bladder is getting continuous with the urethra. Now let's start with the relations of the individual surfaces of the urinary bladder. Now to understand this picture, imagine you are inside the pelvic cavity, and from the inside of the pelvic cavity you are looking outside. So this is a posterior view. What can you see? You can see the rectus abdominis muscle out here. So this is the internal aspect of the rectus abdominis muscle. These are the pubic bones which are present out here, and we are inside, and this is the urinary bladder. What we see clearly is the base of the urinary bladder, and you can see the two ureters entering. This would be the base of the urinary bladder, and this would be the superior surface of the urinary bladder. This right at the end is the apex. That was your pointed index finger. This is the apex of the urinary bladder, and from the apex you can see a structure which is continuing towards the umbilicus. This is the urachus. The urachus is the remnant of allantois, what you studied in embryology. Go back, revise, and then you'll be clear about it. Now this is also known as the median umbilical ligament, and when the parietal peritoneum moves on it, it forms the median umbilical fold. Also in this picture, you can see the other structures which are running with it. This is the median umbilical fold, which is formed by, this is the median umbilical fold was the urachus. This is the medial umbilical fold, which is formed by the obliterated umbilical artery. And this is the lateral umbilical fold, which is formed by the inferior epigastric vessels. All these structures are an important laparoscopic landmark. What do you mean by that? Now, when we are doing laparoscopic surgery, you have understood this, that you have scopes which are going inside. You have not opened the patient completely, but you have scopes which are going inside the patient. You are doing whatever needs to be done from within without opening the patient. Now, when you're looking in the abdominal cavity through these scopes, you need to have some structure which gives you a bearing of where you are, which is the anterior aspect, or whether you're looking at the anterior aspect or posterior aspect in the abdominal cavity. So at that time, these structures, these folds, the median umbilical fold, the medial umbilical fold, and the lateral umbilical folds form important laparoscopic landmark. The urachus is also said to anchor the bladder to the anterior abdominal wall. Now, what is the other importance of the urachus? The other clinical significance of urachus is that it can result in certain conditions like the urinary fistula, urinary cyst, and a urinary sinus. Now let's understand these. Usually the urachus gets fibrosed completely. There is this structure which is moving from the urinary bladder towards the umbilicus, and barring a few centimeters out here, the remaining part of the urachus is usually fibrosed all the way up to the umbilicus. However, if it remains patent, as in this particular condition, it results in urachal fistula. Now, every time the urinary bladder contracts to expel urine, the urine will not only move towards the urethra, but also move towards towards the umbilicus through this patency which is there, the urachal fistula. This would results in weeping umbilicus. Another condition which can take place, that it gets fibrosed in its lower part as well as in the upper part near the umbilicus, but in the middle a part of it remains patent. Now this patent area is lined by mucosa which starts secreting secretions, and after some time the secretions get accumulated to form a urachal cyst. Another condition which can exist is the urachal sinus. Now the part which is near the urinary bladder gets fibrosed, but distally this particular area is still patent and it is lined by mucous membrane again. So this mucous membrane also starts secreting and it results in urachal sinus. The base of the urinary bladder. Now it's a triangular area which is lying right opposite the apex of the urinary bladder. So this was the base of the urinary bladder. At the superior lateral angles enter the ureters. The two ureters enter at its superior lateral angles and the urethra is present at its inferior angle. Now in both sexes, that is in males as well as females, the base of the urinary bladder is separated from the rectum by organs which are the part of the reproductive system, and these are the internal organs of the reproductive system. In males, now the neck of the urinary bladder in males is surrounded by the prostate. So this is the prostate, but this is the surface which we are talking about, which is the base of the urinary bladder. So in males, present in the adjacent to the base is present the seminal vesicles. These are pyriform structures, that is pear-shaped structure with an apex and a duct which is present out here. These are convoluted and these are responsible for secretion of secretions of fructose, mucus, enzymes, etc., which are needed for the nutrition of the spermatozoa. The duct, this is the duct, okay. Now the other structure is the vas deferens. The vas deferens is the duct of the testis and the epididymis. This is carrying the spermatozoa. This part of the vas deferens, which is present in relation to the base of the urinary bladder, is dilated and is known as the ampulla. This joins the duct of the vas deferens, joins the duct of the seminal vesicles to form the ejaculatory duct in the prostate, and together they open in the prostatic part of the urethra. So the base of the urinary bladder in males in its lower part is related to the seminal vesicles as well as the ampulla of the vas deferens. Now to complete the relations of the base of the urinary bladder, we need to discuss the peritoneum coverings of the male pelvis. Now this is the parietal peritoneum which is present on the posterior abdominal wall. From there it moves over on the rectum. It moves in such a way that it covers the lateral part and the anterior surface of the upper 1/3 of the rectum. It covers the middle part of the rectum only on its anterior surface, and from here it moves on to the tip of the seminal vesicle. At the tip of the seminal vesicle, it turns, covering 1.25 centimeters or half an inch of the base of the bladder before it moves on to the superior surface of the urinary bladder. From the superior surface, it moves on to the inner aspect of the anterior abdominal wall. Now this movement, moving from the rectum to the base of the urinary bladder, in this process it forms a pouch of peritoneum which is known as the rectovesical pouch, or a potential space which is formed. So the base of the urinary bladder is separated from the rectum by the rectovesical pouch in its superior aspect. So that means the base, part of the base, at least half an inch of the upper part of the base is peritoneum. It is covered by peritoneum. Then in its inferior part, it is separated from the rectum by the seminal vesicles, and the two seminal vesicles and the two ampulla of ductus deferens in between, or the vas deferens in between we saw. But there's another structure which is present out here. Can you see between the rectum and these organs of the male reproductive system, which is known as the denonvillous fascia, which is separating again the base from the rectum. What is the denonvillous fascia? So this rectovesical pouch in adults is present at a distance of about 7.5 centimeters from the anal opening. However, in fetuses, it is seen that it extends all the way up to the floor. So this is the extent of the rectovesical pouch. During development, these two layers come in close contact with each other and start to adhere with each other. Just like you saw, the second layer and the third layer of greater omentum had adhered to each other. Similar process of zygosis takes place out here also. So what remains instead of this rectovesical pouch, which is extending all the way up to the anal to the pelvic floor, what remains is the Denonville's fascia, right? So this is the origin, how the Denonville's fascia is formed, and it's an important clinical landmark, especially when when the surgeons are operating on the rectal cancers or prostatic cancers and urinary bladder cancers. Then it is an important structure to remember. Okay, so now completing the base. The base is separated from the rectum superiorly by the rectovesical pouch, inferiorly by the seminal vesicles and ampulla of vas deferens. There are two seminal vesicles and two ampullas of vas deferens, and the Denonville's fascia. Now, another important, the close contact between the male reproductive system structures, internal reproductive structures, and the rectum has been utilized by the clinicians during per-rectal examination. So, by doing a per-rectal examination, they can palpate for the prostate as well as a pathological seminal vesicle. Now, what happens in the female pelvis? What are the relations of the base of the urinary bladder in females? Again, let's start with the peritoneum. The peritoneum moves from the posterior abdominal wall onto the rectum. Now, again, it covers in the upper 1/3 the anterior surface as well as the lateral surface of the rectum is covered. In the middle 1/3 it covers only the anterior surface. From here, it moves over the posterior surface of the uterus, the vagina as well as the uterus. This results in the formation of a recto-uterine pouch. It moves on to the anterior surface. It covers the anterior surface of the rectum, of the uterus. It covers the anterior surface of the uterus, and at the level of the internal os, that is where the uterine body gets continuous with the cervix, it moves on to the superior surface of the urinary bladder. It covers the superior surface of the urinary bladder and thereafter moves on to the anterior abdominal wall. So the base in females is non-peritoneal. It is not covered by peritoneum. The upper surface is not covered by peritoneum like in males. It is related to the supravaginal part of the cervix as well as to the anterior vaginal wall. The base is related to the anterior vaginal wall and the supravaginal part of the cervix. The inferior lateral surfaces. Now the inferior lateral surfaces are below the peritoneum. So the peritoneum, now this is what you're seeing is a coronal section. So the peritoneum moved from the lateral pelvic walls over the dome of the urinary bladder and then moved on to the other lateral pelvic wall. So this part, the inferior lateral surfaces, these are the two inferior lateral surfaces, are separated from the levator ani and obturator internus by this pad of fat. This again is the retropubic pad of fat. So the inferior lateral surfaces are not covered with peritoneum. They are in relation to the levator ani and the obturator internus. The two inferior lateral surfaces meet below the apex at the anterior border, and these are related to the retropubic space, which contains the vessels and nerves which are going to be present out here. So again, now we are seeing from the top, inside the pelvic cavity. This is the urinary bladder. This is the apex. It has been reflected. So this space which is separating the urinary bladder from the pubic bones and the pubic symphysis, and this space on the side is the retropubic space. The retropubic space of Red's is a horseshoe-shaped space. Horseshoe-shaped space contains the retropubic pad of fat, which is basically made up of loose areolar tissue and contains the vesical plexus of veins in it. The neck of the urinary bladder. This is the most fixed part of the urinary bladder. It is present 3 to 4 centimeters behind the lower end of the pubic symphysis. just above the pubic symphysis. It is the site of the internal urethral orifice. So urethra, imagine the urethra like a tube. So the internal tube, the internal end of the tube is the one which is in contact with the urinary bladder at its neck. In females, it is related to the anterior vaginal wall. If you look at the diagrams of the male and the female pelvis, you will be able to understand this. So in females, it is related to the anterior vaginal wall. In males, it is surrounded by the prostate. The base of the prostate is present in attachment to it. Now, to the neck of the urinary bladder are attached important ligaments. These are the pubovesical ligaments in females and the puboprostatic ligaments in males. They extend from the neck of the urinary bladder to the lower part of the pubic symphysis, and these also help to anchor the urinary bladder in its position. The superior surface of the urinary bladder. The superior surface of the urinary bladder is covered with peritoneum, variably in male and female pelvis. I hope you know how to draw both these diagrams. They are very, very important. In the male pelvis, this is the superior surface. It is related to the coils of ileum and the sigmoid colon, and it is covered with peritoneum completely. In cases of female pelvis, the entire superior surface is not covered by peritoneum. It is related to the anteverted uterus, as well as a part of it, of the superior surface, is related to the supravaginal part of the cervix, from which it is separated by connective tissue, and the superior surface is also related to the utero-vesical pouch. Now, what happens when the bladder distends? When the bladder distends, it arises and moves from the pelvis, from the area of the lesser pelvis into the area of the greater pelvis, and comes in contact with the anterior abdominal wall. When it gets reflected, see, this part of the urinary bladder has moved between the anterior abdominal wall and has stripped off the peritoneum from it. So the peritoneum has got stripped off. The urinary bladder has moved in that space which is present between the anterior abdominal wall and the peritoneum. The peritoneum has been moved away, stripped away from the anterior abdominal wall by the expanding urinary bladder. Normally, it can move up to 5 to 7 centimeters above the pubic bone. Now its surfaces and borders have changed. The anterior border would get expanded to accommodate the urine. So now it has an anterior inferior surface and a posterior superior surface, apart from the two lateral surfaces, an apex and a base which is still fixed and it's in its usual position. Right. Now, there are certain important aspects which are associated with the superior surface of the bladder and a distended bladder. Now, if this distended bladder gets ruptured usually due to trauma. Now, in case the rupture of the bladder is on this anterior inferior surface, that is the part which is below the peritoneum, in between the anterior abdominal wall and the peritoneum, this particular part. If this part surface ruptures, this is known as an extraperitoneal rupture of the urinary bladder. And how would it rupture? Due to fracture pelvis. A pelvic bone may get fractured and it may tear the urinary bladder, resulting in urine as well as blood extravasating all over this particular area. Okay? So this is extraperitoneal rupture of urinary bladder. In case due to trauma, which however it is, the superior surface gets ruptured. Now there would be a breach in peritoneum and the urine as well as blood would extravasate into the peritoneal cavity. So this is about the bladder rupture. The next important point which we do is for the urinary retention, for understanding urinary retention and suprapubic cystoscopy. Now, for whatever reason, the bladder is unable to function, and that is the urine does not pass, it gets accumulated in the bladder, but it does not pass from the bladder out. It does not expel to the exterior. So, what are the options which a person has? Either a urethral catheter can be passed, that is through the normal passages of the catheter, through the entire urethra into the urinary bladder, and then the urine would get expelled outside, in which would be collected in a bag. Now, for if there is an injury to the urethra and there is a stricture, that is narrowing of the urethral passages, so the urethra, we cannot pass this catheter into the urethra. What would we do then? we would do what is known as a suprapubic cystostomy. We would take advantage of the fact that the bladder has come in contact with the anterior abdominal wall, and it is in contact of, it can be in contact about 5 to 7 centimeters. So a catheter is passed above the pubic bones. That is why suprapubic catheter into the urinary bladder to expel the urine. Some small procedures can also be done through this methodology, through the suprapubic cystostomy passage. Now let's discuss the interior of the bladder. Now we need to know how the normal bladder interior looks like, because what we started, our case in the beginning of the lecture had a cystoscopy which was done on it. By cystoscopy we mean a tube fitted with a lens is introduced into the bladder, that is, a cystoscope is introduced into the bladder to look at the bladder from the inside. So we should know what is the normal before we can decide anything abnormal which is present. The entire mucosa of the urinary bladder is thrown into folds. These folds tend to disappear. These folds tend to disappear when the bladder distends with urine. However, there is a part of the area which is smooth, this triangular area, which is present on the interior of the base of the urinary bladder, is known as the trigone. At the two ends of this triangular area, at the two superolateral ends, are the ureteric orifices, and at its apex is the opening or the internal urethral orifice. The ureters, when they enter into the bladder, pierce the bladder musculature. After they have pierced the bladder musculature, there is a part of the ureter which runs inside the muscular walls, and this is known as the intramural part of the ureters. These ureters then open through oblique openings. These urethral orifices are oblique inside the bladder. It is important to remember the shape, because in case of certain diseases it becomes circular. So to be able to differentiate, we should know normally it is an oblique opening, and at this oblique opening we usually can see urine being ejected out by peristalsis at the rate of 4 to 5 drops per minute. Now the two urethral openings are joined by the interureteric crest or the interureteric fold. This is formed how? The longitudinal coat of muscles of the ureters of both the sides become continuous with each other and form a triangular layer of muscle underneath this entire mucosa, which is known as the superficial muscle, trigonal muscle of Bell. So underneath the mucosa, instead of submucosa being present, in the trigone is the superficial muscle of Bell, and then is the detrusor. So normally if I was to talk about the the walls of the urinary bladder, at this point it would be mucosa, submucosa, then the detrusor, and then the connective tissue on the outside. Out here in the area of the trigone, it would be mucosa. Underneath it would be the superficial muscle of trigonal muscle or muscle of Bell, and thereafter would be the detrusor and then the connective tissue. And that is why, because there is no submucosa out here, the mucosa appears smooth. This at its lower or the apex of the trigone is the urethral opening. Now the distance, in case the bladder is empty, the distance between this between the two urethral orifices is about 2.5 centimeters, and it becomes 5 centimeters when the bladder is distended. Another structure which is seen in middle-aged men is just behind the urethral opening would be Uvula Vesicae. Now, what is Uvula Vesicae? The median lobe of the prostate, below the urinary bladder in males, is the prostate. The median lobe of the prostate, which tends to start enlarging with age, tends to protrude in the interior of the urinary bladder and raises a projection which is known as the Uvula Vesicae. During cystoscopy, what is seen in the urinary bladder? The entire mucosa is thrown into folds except in the region of the trigone. The mucosa is pink. The mucosa over the trigone is smooth, An interureteric ridge can be seen, which helps you again to get it acts as a guide and get the bearing, gets the surgeon his bearing, and the urethral orifice can be seen. Then also the shape of the urethral orifices has to be noticed, and also what has to be noticed is that the urine is ejecting out by peristalsis from these urethral orifices. So in our case, the cystoscopy was performed, that is through the urethra. A cystoscope, which is a tube with a lens fitted in it, was passed into the urinary bladder, and in that particular gentleman there were tumors out here. The tumors were resected and removed, so that those tumor masses were responsible for the hematuria which the patient was having. The tricone is embryologically different from the rest of the bladder. You need to find out why. It is the most fixed part of the urinary bladder, and the mucosa here is smooth. So this is how the trigone is different from the rest of the urinary bladder. The ligaments of the urinary bladder. As we've already discussed, the neck of the urinary bladder in females is connected to the lower border of the pubic symphysis by pubovesical ligaments, and these become the puboprostatic ligaments in males. Let's try and understand this complicated looking figure. Now this is the interior of the pelvis. We are looking from the top. We've chopped off the various organs. So what are we seeing out here? This is the open end of the urinary bladder, whose dome and the upper surfaces have been, superior surface has been removed. The uterus has been removed, and this is the cervix which we are seeing, and this is the rectum. This is the lateral pelvic walls, and the viscera is present in the midline. Now from the, look at this side goes on a more superficial plane, and this side represents a deeper plane, more on the towards the pelvic diaphragm. Okay. Now the urinary bladder has certain ligaments attached to it. These ligaments are condensations of pelvic fascia. Now on the lower aspect, that is nearer to the pelvic diaphragm, are the pubovesical and the puboprostatic ligaments. So here from the neck of the urinary bladder going towards the pubic bone, this is the pubic bone, as well as going towards the white line which is present on the levator ani, are the medial and the lateral pubovesical ligaments. To the apex is attached the urachus, right? That is also a ligament. And above, more superficially, more towards the abdominal aspect, is attached the lateral ligaments of the urinary bladder. Now what are these ligaments? Look at the blood vessels. This is the external iliac vessels. These are the internal iliac vessels. The viscera is present in the midline. The vessels are present laterally and posterior laterally actually. From the vessels arise, this internal iliac arise branches which are going to supply the various viscera. Now while these vessels are moving towards the viscera, there is condensation of the pelvic fascia happening around it, and this condensations of the pelvic fascia results in formation of ligaments. And with the urinary bladder moving is the lateral ligament. The lateral ligament extends from the base of the urinary bladder to the lateral pelvic wall, and in this are present the various vessels and nerves and the veins which are present, which are going towards or going away from the urinary bladder. Also related to the urinary bladder, which is another set of ligaments which connects the urinary bladder to the sacrum, and these are known as the sacrogenital folds or the sacrogenital ligaments. So these are actually true ligaments, and in these ligaments we have to remember our vessels and nerves which are running through it, because when we are trying to remove the urinary bladder, we will need to clamp the vessels out here, and they at that laterally, and they are present in these ligaments. So these ligaments act as a landmark for moving towards the urinary bladder. The blood supply of the urinary bladder. As we saw, these blood vessels are present, the arteries are present and the veins are present in the ligaments. Now, since this is one of the first visceras which you're doing and you haven't really studied about the blood vessels, this is the abdominal aorta. The abdominal aorta divides into the two common iliacs. In front of the sacroiliac joint, the common iliacs divide into an external iliac and an internal iliac. The internal iliac divides into a posterior division and an anterior division. The posterior division supplies mainly the pelvic walls and the gluteal region. The anterior division gives rise to vessels, the arteries, for not only the viscera but also the pelvic wall. Now we need to see two important vessels. The superior vesical artery. The superior vesical artery is a branch of the anterior division of the internal iliac, which supplies the superior surface and part of the inferior lateral surfaces of the urinary bladder. The proximal part of it is the superior vesical artery. The distal part of this vessel, which moves on to the anterior abdominal wall to form the obliterated umbilical artery. The inferior vesical artery, which supplies the base, it also gives rise in males, it also supplies the prostate, the seminal vesicles and other structures, could be a branch of either the middle rectal artery or the anterior division of the internal iliac. In females, it is a branch of the vaginal artery. Together, the superior and the inferior vesical artery supply the urinary bladder. They move from the lateral pelvic walls towards the midline where the urinary bladder is situated. The veins. The veins of the urinary bladder again now move from the medial aspect towards the lateral pelvic wall within these ligaments. They form a vesical venous plexus, which in males is present at the junction between the urinary bladder and the prostate. From here arise the vesical veins, which move into the internal iliac veins, then the common iliac veins, and thereafter into the inferior vena cava. We will discuss the importance of it when we are doing the male reproductive system. The lymphatic drainage. There is a widespread lymphatic drainage from the urinary bladder. It moves towards the external iliac lymph nodes. Mainly, the lymph drains towards the external iliac lymph nodes. From there, it moves towards the common iliac lymph nodes and then to the lymph nodes which are present around the abdominal aorta. Some of the lymph nodes also move towards the internal iliac group of lymph nodes. Some of the area also drains towards the internal iliac group of lymph nodes and the obturator nodes which are present in the pelvis. The innervation of the urinary bladder. Now this is the tricky part of the entire urinary bladder, the innervation. Because it's a viscera, it is going to be supplied by the autonomic nervous system. That is, it will have a sympathetic set of nerves coming to it and a parasympathetic set of nerves which are going to be coming to it. And it has to perform what function? One, it should be able to fill and then it should be able to contract to expel the urine. To be able to do that, it has the sympathetic nerves which are coming to it and the parasympathetic. Now this is the sympathetic chain which is running on the lumbar vertebrae on both the sides. It's running right from the base of the skull to the first coccygeal vertebra where both the sympathetic trunks of both the sides join together to form the ganglion impar. They are running behind the iliacs. Now from the sympathetic trunk arise the lumbar splanchnic nerves. Do you remember splanchnic nerves? We had done them in thorax. The greater, the lesser, the least splanchnic nerves. That is, what are these? That is, splanchnic nerves are those in which the preganglionic sympathetic fibers do not synapse in these ganglions but moves unsynapsed to some other area, to some other plexus where they synapse. So these nerves come together, the lumbar splanchnic nerves come and form the superior hypogastric plexus in front of the sacral promontory. So we have lumbar splanchnic from one side, the lumbar splanchnic from the other side, and from above medially is coming the intermesenteric plexus. Together they have formed a superior hypogastric plexus. Now these splanchnic nerves now synapse in the superior hypogastric plexus, the ganglion cells which are present there, and the postganglionic splanchnic fibers then tend to form two inferior hypogastric plexus, that is the right and the left inferior hypogastric plexuses, which move on the lateral side of the viscera. So these are the two hypogastric plexuses which are going. So this is the superior hypogastric plexus and these are the two inferior hypogastric plexuses which are moving on the sides of the viscera. You can see them moving on the sides of the rectum as well as the urinary bladder. So this is the male pelvis. Now also joining these are the pelvic splanchnic nerves. These are the parasympathetic component of the pelvic innervation, which arises from the pelvic splanchnic nerves, that is the sacral segments of S2, S3 and S4. The spinal segments of S2, S3, S4 had that nucleus of Orloff in it, which gives rise to the pelvic splanchnic nerves. These are again preganglionic parasympathetic fibers which have joined these hypogastric plexuses. Now this plexus, when it's near the rectum, will be supplying the rectum, so this is the rectal plexus, and when it comes in near the urinary bladder, we will call it as the vesical plexus. The autonomic innervation of the urinary bladder. The sympathetic part comes from the lumbar splanchnic nerves, which arise from T10 to L2 spinal segments. They enter the preganglionic fibers, enter into the superior hypogastric plexus, from which arises the postganglionic fibers, which now run and form the inferior hypogastric plexus. The sympathetic fibers inhibit the detrusor and stimulate the sphincter vesicae. That is, they are going to help in filling of the urinary bladder. I'll come to it again. The parasympathetic fibers arise from the pelvic splanchnic nerves. They also form a part of the inferior hypogastric plexus. They stimulate the detrusor and inhibit the sphincter vesicae. Now, this is the urinary bladder. Now look at this. Now the urinary bladder is going to get this innervation from the sympathetic system. This will be the internal urethral orifice, where there is this sphincter vesicae in internal urethral orifice, and this will be the external sphincter. The external sphincter is under voluntary control. It is being supplied. This was the muscles of the urogenital diaphragm, the sphincter vesicae which was present. This is being supplied by the pudendal nerve. Whereas the urinary bladder and the internal sphincter is going to be supplied by the autonomic nerves. For filling to take place, the detrusor should be relaxed, the bladder neck should be closed, and the external sphincter should also be contracted. For voiding to take place, the detrusor should contract and the bladder neck should be relaxed, the muscles should be relaxed, as well as the external sphincter should be relaxed. Right? Now, how does the voiding reflex takes place? Let's start from infants. In infants, when they are born, you see that they just tend to urinate. They have a feed and then they tend to urinate. So what is happening? Reflexes or the afferent information is going from the bladder to the spinal cord. The spinal, once it fills up, the information goes from the bladder to the spinal cord. A reflex efferent information passes via the pelvic splanchnic nerves and the pudendal nerves to the bladder, which causes the infants to urinate. So the bladder fills and a reflex, autonomic stretch reflex takes place, and the bladder contracts, and the infant tends to, till toilet training is done, the infant tends to urinate wherever the child wants to. Once the toilet training has taken place, now what happens? The afferent information passes from the urinary bladder, and this information usually passes via the pelvic splanchnic nerves to the spinal cord, to the Orloff's nucleus. From here, the information travels via the fasciculus gracilis to the nucleus gracilis, through the medial lemniscus, some fibers going on to the pons, to thalamus, the paracentral lobule, and the inferior frontal gyrus. When the time is right, when the correct place is there, then the inferior frontal gyrus sends the information via the upper motor neurons of the pyramidal and extrapyramidal tract to the spinal cord, and via the pelvic splanchnic nerves and the pudendal nerve, then the bladder, that is the detrusor, contracts and the sphincter vesicae relaxes, the internal urethral orifice relaxes, and then the person tends to urinate. That is the higher control which comes in for the control of the voiding reflex. Pain from the urinary bladder travels via the sympathetic fibers to the spinal cord and moves via the spinothalamic tract to the thalamus, and thereafter to the various areas of the brain. Now, what happens when there is disruption? How does the disruption of micturition take place? Now, there is a spinal cord injury taking place, right? Now, depending upon where the spinal cord injury is, the effects of that injury will come on the urinary bladder, just like what we have done for various other sensations. Now, if there is a spinal cord injury, say at the upper levels at this present moment, above the sacral segments, now there is a spinal cord injury which is taken place. The person is initially in the phase of spinal shock. The bladder is atonic and hyporeflexive bladder. That is, it distends and it finally overflows. The detrusor muscle is relaxed, the sphincter vesicae is contracted, and the sphincter urethra is relaxed. So it just distends to its capacity which it has to distend, and then it tends to overflow. Now, after a few weeks, when the patient has been stabilized and all those whatever spinal reflexes, whatever reflexes had to come back and whatever neural activity has returned, the patient will have an automatic bladder. What do you mean by an automatic bladder? Now the spinal cord is injured, right? So the information is not moving from the spinal cord to the higher centers. So bladder fills and it empties reflexively every 1 to 4 hours. It becomes like young children before toilet training. It's a simple reflex act. It fills, it empties. It fills, it empties. It is an automatic reflex bladder or a hyperreflexic bladder, because again and again it fills and empties, it fills and empties. Then the detrusor muscle tends to become it hypertrophies, and the reflexes become very, very hyper, and there's a small capacity bladder which takes place. So this automatic bladder is an important competency, as we had discussed in the beginning of the chapter. What is an automatic bladder? That is, it is one in which there is no connection between the spinal cord as well as the brain. There is an upper motor neuron injury which has taken place. It becomes, the reflex is acting on its own without the intervention of the higher brain center. It fills, it empties. So it is automatic. It's on its own. It can function. Now, if there is an injury in the sacral segments, or these afferents, the pelvic splanchnic nerves are destroyed, or the pudendal nerves are destroyed. Now, what has happened is, how can they take place when you are performing a surgery on the prostate, radical prostatectomy, and surgery is being done, or an hysterectomy is being done. Now, these afferent efferents can get damaged, or suppose there is an injury to the spinal cord, sacral segments are destroyed. Now, the bladder is without control from the sacral segments also. So what will happen? The wall will become flaccid. It fills to its capacity and it overflows. There is continual dribbling. अब तो उसके ऊपर कोई भी असर नहीं. There is nobody responsible. There is nobody controlling it. It is an autonomous bladder, right? So you need to understand the atonic bladder, automatic bladder, and autonomous bladder. Automatic may reflex, the sacral reflex, spinal cord reflex is intact. Whereas in an autonomous bladder, there is no reflex action taking place. There is no higher center, there is no reflex action at the sacral segments. It's a lower motor neuron type of a lesion which has taken place. With this, we come to the end of the lecture. What you need to do is, you need to know what are the important diagrams which you need to make. So you need to make this diagram which tells you the relations of the male urinary bladder. So you should be able to make this diagram. This was the area of the rectovesical pouch, which is related to the superior part of the base of the bladder, and then the two seminal vesicles with the ampulla of the vas deferens in between, which is related to the inferior part of the urinary bladder. Thereafter would be the fascia of Denonvillers, and then would be the rectum. So this is an important diagram which you need to know how to. The other is a diagram which tells you about the various surfaces and borders of the urinary bladder. The third is a diagram of the interior of the urinary bladder. Please see to it that you made all these diagrams along with the peritoneal relations of the male and female pelvis in your files.